Greetings, everyone, once again. Welcome to the 186th session of the online Optom Learning Series, OOLS. And for today's session, we are pleased to have with us Dr. Lindsay Sicks. Dr. Sicks has been with us and shared her experience in one of the previous sessions. To just give you a brief about her, she has received her optometry degree at the Illinois College of Optometry in 2010. And she has also done her residency program in cornea and contact lenses at the Northeastern State University. Her current role is as the associate professor and also an attending optometrist for the third and the fourth year interns in the Cornea and Contact Lens Center at the Illinois Eye Institute. Dr. Sicks is a fellow of the American Academy of Optometry, fellow of the International Association of Contact Lens Educators, and also holds a fellowship from the Sclerolens Education Society. Very recently, and I'm very proud to say that she's also been awarded by IACL as the Contact Lens Educator of the Year for the Americas region. And today she's taken out her time and put this together, a large report which came out by the BCLA to kind of summarize and tell her views and share her understanding and probably the best outcomes of the BCLA Clear report with us. And with that, I would like to welcome you, ma'am, and leave the screen time to you.
Great. Thanks so much for having me. It's great to be back. I can't believe you guys are on a number 186. That's so awesome. So I'm glad to be back and contributing again. When the BCLA's Clear report came out, I kind of was really overwhelmed by the 300 pages worth of evidence-based information. And I started reading through those and just thinking about, well, what can I take out of this report and share with my students? Like, what are the most clinically relevant pieces for them? And I'm certainly not going to cover everything that's in the report. I'm not even going to get to some of, I think, the most important parts of the report, but I really wanted to share with you some of the highlights and things that I think will affect you in your educational career and as you're out in practice, and just kind of things that really stood out to me as really interesting or novel. So the Clear report wrote that it is a reasonable expectation of patients that eye care practitioners base their decisions on the best available scientific evidence, and that this helps us maximize success for our contact lens wearers, maintain satisfaction with contact lens wear, retain wearers, and grow our contact lens business. And this was actually part of a Clear summary that was put out by Contact Lens Update. It's kind of paraphrasing a piece of the evidence-based practice report. And I put a QR code here if you want to pull up that summary. You don't have to read it right now, but it is a very nice resource for you, even as you're in clinic, of some of the highlights of the various pieces of the report. So CLEAR stands for Contact Lens Evidence-Based Academic Reports, and this was an initiative of the BCLA, and it was published in the journal Contact Lens and Anterior Eye. There were 11 total reports that were published out of this. There were 10 committee chairs that helped pull the majority of the work on these reports with the help of 102 authors. And all of these individuals were based in 16 different countries. So not only the US, but also various academic centers and clinical practices around the world contributed to pieces of this report. So it's really cool that they have a global perspective on everything evidence-based as it relates to contact lenses. So we can go ahead and launch the first poll question. Have you read any of the articles in the CLEAR report?
All right, so I have just launched it, and I think people have started to put their thoughts. So yeah, we'll keep it another 10 seconds for you to kind of just tell us a yes or no. I mean, we just want to know, have you had a chance to read through any of the articles? As Dr. Sicks mentioned, there are 11 reports, 11 articles there. So probably you have a chance to read one or probably more of them. All right, great. So I'm just going to end this. So I think majority of our attendees today have not gotten a chance yet. So this would be something, thank you for sharing the QR code. That would be leading them to that, and also for doing the session. Yeah.
Yeah. I kind of anticipated that, right? I think people out in practice probably haven't read the reports or even one of the full reports, but it's nice to know kind of your baseline level of knowledge. And those of you that have read it, maybe you have some other learnings that you took away from them as well. So it would be interesting to have a little chat over coffee about what your favorite parts were, those of you that did read them. So these are the 11 academic reports. I mentioned there were 10 committee chairs. It's because there are actually 10 reports, but the 11th one is the first introductory one. So not that that one doesn't count, it's very important, but the other 10 topics below, as you see here, are kind of where the meat and potatoes of the reports are. So I'm going to walk through these in order. They're mostly by header based on the report. Some of them have a little bit of subheading related to them, but we are going to go in order, basically. So you can follow along with these or make a note of which one you think you really want to read based on what you hear today. So the whole idea behind CLEAR, again, being evidence-based, is that it sets the standard for us as eye care professionals and in how we use evidence-based information to care for our patients. One other great thing about it, especially for you students, is that it highlights opportunities for future research in the field of contact lenses. So while they're kind of laying out the different, what we do know versus what we don't know, they're kind of highlighting areas where we need more research to prove something one way or the other, or to better understand the mechanisms or etiologies or treatments for certain things. So if you're looking for a research project, the CLEAR report as it relates to contact lenses is really a one-stop shop to figure out what you could look at in terms of future knowledge in research. So a couple big highlights from the first report, which is the anatomy and physiology of the eye. You guys may be familiar with Bowman's membrane and Descemet's membrane, and these are two layers of the cornea that we commonly refer to. And the kind of newest recommendation that the CLEAR report follows is that we look at the Federative Committee on Anatomical Terminology. And this committee, their goal is really to take away the eponymous terms, things that are named for individuals or people, and to give them more standardized terminology that doesn't include someone's name so that we can all call it the same thing and know exactly what we're talking about. So their recommendation is that we change our terminology from referring to Bowman's membrane to instead calling it the anterior limiting lamina of the cornea. And then when we talk about Descemet's membrane, we call it the posterior limiting lamina of the cornea. There are several other eponymous terms, and there's a table in the report that kind of goes through which terms they highlighted and chose to give an alternate name. But I will say that one notable exception that the group that wrote this report came to a consensus on was they didn't want to rename meibomian gland as a tarsal gland, which is really, if you're taking the name away, it's a gland of the tarsal plate. And they decided, I think, that meibomian gland was so entrenched in the literature that changing it now was probably a little bit futile. And everyone really knows it as a meibomian gland. And so that's the notable exception to this FCAT adoption of terminology. So here's just a quick table. It's table 1 of that first report. So you can go there and look at all the different options, but you'll see the first one, anterior limiting lamina, Bowman's layer, and then a little further down, posterior limiting lamina, Descemet's membrane. So the report itself, I'm not going to go through the anatomy, physiology, and function, but if you're an anatomy nerd this is a really great report to read because it really reviews all of the different parts of the eye, what their physiology is, what their functions are. And it really goes through the tear film in great detail in terms of components, structure, how it drains, and what your kind of average values are, including how the pH is determined. So if you're studying for your board exams or your final exams, or really just want a nice overview of the tear film and the cornea, this is a great place to start. A couple highlights here. Remember that the lacrimal gland secretes proteins and electrolytes into the tear film. It helps maintain the immunity and health of the ocular surface. And one reason I chose to highlight the lacrimal gland here is because we very often see components of the tear film, those proteins and electrolytes, depositing onto contact lens materials. And this can affect greatly how our patients see the visual performance of their lenses. So they may have changes to vision or changes in contrast or changes to their vision, depending on deposits that are on their contact lens. I don't know about you, but when I tend to think of complications, which we'll get to a little bit later, it has its own report. One of the things that was mentioned in the first report was that corneal hypoxia and papillary conjunctivitis are rarely seen. And I guess I'm a little shocked to see that they were mentioned as rare complications because I tend to see them quite often, especially papillary conjunctivitis. And maybe that's a factor of how lens wear happens in the US, but I want you to think about your practice and how often you see corneal hypoxia from contact lens wear and papillary conjunctivitis, and consider if you think it's rare or not. One other thing to think about here is, corneal hypoxia and papillary conjunctivitis really require us to do something about it. But one of the takeaways from this report was if you see kind of low-grade bulbar conjunctival hyperemia or low levels of ocular surface staining, those are really non-specific indicators of the physiological impact of contact lens wear. So it doesn't really tell you what's wrong necessarily. It just means perhaps something is going on, and then you have to kind of dig a little deeper, use your fluorescein, avert the upper lid, and decide if there's a problem and if you need to solve it. Whereas corneal hypoxia and papillary conjunctivitis are really quite obvious as to what's going on and what you need to do to fix it. One other point here that I found very interesting was they talked a lot about the subclinical inflammatory response to contact lens wear. So the whole idea here being, just by nature of putting a contact lens on the eye, we are likely inducing some low level of inflammation on the ocular surface. And this may have some tie to our patients' physiological responses to contact lens wear, how often they undergo adverse events, and perhaps has a role in contact lens discomfort. But it's also one of those things where we don't have enough research to know, and we can't really make any firm conclusions on the role of inflammatory mediators in the tears and what role that plays in contact lens comfort. So I just wanted to shout out Dr. Maldonado Codina, who is also one of the IACL award members this year, but she's a co-author on this report talking about subclinical inflammatory response to contact lens wear. So that's another nice read if you're looking for some more information on that. So let's launch poll question number 2.
All right, so I've launched the poll, and this is if you have any idea about the abnormal tear film osmolarity readings, what is considered to be an abnormal value. I think people who have read the report probably would get that bang on right. Those who have not, you will have to use probably some common sense or a guesswork.
I think my answers were a little tricky, so we'll see how it goes.
That's why I said common sense, maybe. All right, so I'm just gonna end it within the next 5 seconds, and share the results. There we go.
Ooh. All right. Oh, I love it. Okay. So a lot of you thought 280, and I think next was 330. So we'll dig into a little bit what the norms are here. And again, I'm a big like trivia buff. So if you can give me trivia about eyeballs, even better. So here's some of your key takeaways in terms of trivia for the eye. So from the report, the normal tear film pH is somewhere between 6.8 and 8.2. Usually think about 7, right? Normal tear osmolarity is quoted as anywhere between 270 and 315. So anything above 315 would be abnormal. And I'm with you. Those of you that chose 280, I think that's really low, but it's also not necessarily bad, right? It's when we get really hyperosmolar that we have a problem. So if that's something you're measuring in your practice, it's a good to know the cutoff. And then the number of meibomian glands on the upper and lower lid is up to 40 on the upper and up to 30 on the lower. So you have quite a few glands on your upper and lower, more on the upper than the lower. All right, so let's talk a little bit about contact lens wettability, which moves us into the next report. So if we look at wettability, there's kind of two ways to look at it. It's in vitro, which is in a laboratory, and on the eye, which is in vivo. So in vitro versus in vivo. And there's kind of some controversy on whether the tests we do in the laboratory translate to on-eye wettability. And that has implications for contact lens comfort or discomfort. So when we're measuring wettability in vitro, we look at the contact angle, which is the inverse of how wettable a material is. And a higher angle means it's less wettable. Remember like that, if you remember like the Cecil drop technique, you look at the angle of the drop on the material. When we look at wettability on eye, we don't have a whole lot of techniques to do this, but usually what happens is we overlay a placido disc and a keratographic image of the lens on the front surface of the eye, and then wait for some measure of breakup to happen of those placido rings or that projected image to give us an idea of when the wettability stops being ideal. So again, there's really not a lot of evidence that connects these two measures, one or the other, to end of day comfort, which I find really interesting because I think we just kind of assume that that's the case. And I think contact lens manufacturers also kind of assume that that's the case. But I think it's also a scenario where we don't really have any other better measures. And so this is something that we do have. So it would be really interesting to have more evidence as to the connection between wettability and end of day comfort. So what is a wetting agent? What makes these materials wettable? When we're talking about soft contact lenses, specifically silicone hydrogel contact lenses, hydrogel contact lenses inherently pick up water, but silicone hydrogel materials have more silicone. And so they tend to be more hydrophobic, meaning they're not as wettable. And so to overcome this from a manufacturing standpoint, wetting agents are added, and they can be added to the lens or the material. And so I've listed some there for you. Some of the ones you might have heard of are hydroxypropyl methylcellulose, HPMC, polyethylene glycol, also known as PEG. PVP is very often embedded into lenses and put into packing solution in PVA. So there's lots of different wetting agents, and they play very different roles, but all have the same goal of keeping that material very wettable for your patient. So again, I mentioned the different areas. We can have these wetting agents embedded in the material. So very often PVP is embedded in lens materials. We can have them on the surface of the lens, hydroxypropyl methylcellulose, it's a tongue twister, is often found there. And then we can have some that are progressively released during wear, like PVA is often one of those released wetting agents. And this really depends on the manufacturer of the lens and what they choose as their internal wetting agent. So What we do know, the evidence shows that these wetting agents promote in-eye performance, meaning the patient perceives the lens as performing better, perhaps the vision is better. Again, we don't really have a link to comfort necessarily, but the evidence also shows us that not one wetting agent is best for all people, which is why it's nice that there's a variety of lenses and wetting agents available to us, and why not everyone feels like the same contact lens is as wettable as the next. So how do we maintain wettability? There's lots of different ways to do this. As an eye care practitioner, one quick way is to make sure your patient doesn't rinse their lens off when they take it out of the package. So this is especially true for daily disposable lenses. I always tell them the good stuff is in the package, right? The wetting agents that are in the solution that's in the blister pack is all the good stuff you want to go on the eye. If you're taking that and rinsing it with solution and then putting it on, you've just gotten rid of all the good stuff. So that's one way to maintain wettability. Making sure our patients are blinking, especially if they have that blink released technology. And then certainly re-wetting drops and prescription dry eye products can help. We can bolster that tear film, treat any underlying ocular surface disease with dry eye medications, and then we can promote wettability with various lens care solutions. When we talk about re-wetting drops and lens care solutions, this is another one of those places where the CLEAR report was really helpful in helping us understand that while solutions and re-wetting drops can impact wettability during wear, we don't really know exactly what products work for which patient, okay? There is evidence to suggest that certain combinations of products or wetting agents perform better. I think if you go into the report and you look at some of those citations, some of those are funded by industry. And so it's hard to kind of parse out what's biased and what isn't. But we do know that the presence of the lens itself is a factor, right? Just putting a lens on the eye has an effect on the tear film. The quality of the tear film, if it's not good before you put a contact lens on, it's certainly not going to get better after we put a lens on. And then we also know that using re-wetting drops really only gives a temporary effect to relieving our patient's symptoms. So here's a nice table to come out of the report. Again, you can dig into the report itself to get this table, but it lists out the different re-wetting drops, which lenses specifically they're compatible with, and what the active ingredients are. In terms of disinfection, we know that contemporary contact lens disinfecting solutions contain various agents, not only to kill bugs, but also to provide wettability with surfactants to buffer the pH of the solution, to preserve the solution so that it doesn't get contaminated. But the main function of solution is to clean and disinfect the lens and to hydrate the lens when we're talking about soft contact lenses, right? We don't want those crispy contact lenses to dry out because they weren't soaked in enough solution. Rigid contact lenses are obviously not using contact lens solution in that way. They are not necessarily hydrated, but what contact lens solutions do for those, in addition to killing bugs, is condition the lens and enhance the wettability prior to lens wear. So still beneficial to clean our rigid lenses and soak them in conditioning agent prior to wear. When we talk about how contact lenses interact with tears, there are the potential to alter our various tear components. So we talked about those proteins and lipids and mucins and inflammatory mediators earlier. And we do know there are alterations with those, but again, we don't really know the impact of those on contact lens comfort or discomfort. There's a little bit of contradictory data out there. And a lot of this is due to how the research is performed, right? There's so many different contact lens brands, so many different scales to use. Different researchers can decide who's symptomatic and who's asymptomatic using their own arbitrary criteria. different lenses are worn for different amounts of time in different studies. And then different care systems are used. And then how they assess their outcome measures in terms of tear breakup time or staining or all those sorts of things all kind of contribute to these differences that we can't really compare apples to apples when we're looking at the impact on comfort. All right, let's launch poll question number 3.
All right, moving ahead in the next section, I guess this question comes from the multifocal related questions, and let's see if the attendees think that pupil size affects the success with multifocal contact lens fitting. All right, we have most of the attendees who have voted, and I'm just going to end the poll and share the results. So majority, I think 90% of them think that yes, it does affect, whereas we have a couple of them who are probably unsure and think that they do not affect.
Yeah. And you know what? I probably would have answered the exact same way until I read the CLEAR report, right? Because I think we inherently think that that's a factor. I think it seems logical that that's a factor, but the CLEAR report determined that based on the current evidence that we have, pupil size does not actually affect the clinical performance of multifocal soft contact lenses. And I think that's a really good thing to keep in mind. It gives us a little peace of mind. We don't need to necessarily pay attention to that when we're choosing or fitting a soft multifocal lens. We can kind of look at other things like the sagittal height of the lens and the patient's needs in terms of near vision and intermediate vision without worrying about the pupil size too much. Now, certainly research may come out in the future showing that that does, and there are certainly studies that kind of pick out different elements of that and suggest that it affects certain things, but overall, the evidence is not strong enough to show that pupil size does affects clinical performance. So we're going to go with the idea that it does not. So those of you that said no, you win. There were only a few of you. We also know that very little evidence informs lens diameter choice. I would urge you to separate in your mind lens diameter from lens sagittal height. So what this is telling you is not just the diameter matters, right? What we do know from some of the studies at Pacific University in contact lens sagittal height is that our lenses that are commercially available have different sagittal heights. And those sagittal heights affect how that lens sits on the patient's eye. And so it's not just the diameter that matters. It's the interaction between the diameter and the base curve and how that forms the sagittal height. The one thing that the CLEAR report did determine is that the diameter does matter, but only to the point at which you need to remember the lens edge really shouldn't touch the limbus, because we don't want that lens edge to rub on the limbus and affect those limbal stem cells. That has other complications that can happen from that. And while we do know that horizontal visible iris diameter affects contact lens fitting, again, as it relates to the sagittal height of the eye and the sagittal height of the lens, the report did confirm that the vertical palpebral aperture is not relevant to contact lens fitting. And I think this is really important because it shows us that just because babies and kids have tiny eyes doesn't mean they can't wear a contact lens. They absolutely can. And it's also not something we need to necessarily be measuring. Our patients that have a ptosis can just as easily wear a contact lens as our patients who don't. So just to kind of bring this all back around, back to, we already talked about wettability, but when we talk about material and design effects on anatomy and physiology, again, there's no clear association between wettability and comfort. We know that there are interactions between the lens materials, between the tear film, contact lens solutions, but we do not know whether increasing the biocompatibility of these factors improves contact lens comfort. So much we don't know about contact lens discomfort. And I say that to my students, I feel like every week, like there's just so much we don't know. But I hope that we're able to learn more. When we talk about contact lens adaptation, something that we teach our students, or I think we have taught our students in the past, certainly the way I was trained, was that when we start patients new neophyte wearers in contact lenses, for soft lenses, we need to build up the wear time slowly. And we called that the 2 + 4 to 12 method, at least where I was trained. And you may hear it called the 4 + 2 method, or the 2 + 2 method, or the 2, 4, 6, 8. There's lots of words for it. What we know is that can now go in the garbage, right? When we talk about modern soft lenses in 2022, we don't need patients to build up wear time slowly. I say that with a little caveat. I think for certain sensitive patients, it can be helpful to give them that guardrail and those parameters. But for most patients, when they ask you, like, how long should I wear these today? And you've just dispensed a new pair of lenses, I usually say, wear them until, you feel like you want to take them out. If they're not comfortable, obviously take them out. But if you're feeling good at 8 or 10 hours, go right ahead. Keep wearing them. And you don't need to build up that wear time slowly. The contrasting lens here is a rigid contact lens. So these do require a longer adaptation period, about 1 to 3 weeks on average. Soft contact lenses do not have that barrier. So with our rigid corneal lens patients, we want to let them know that they're going to experience, I usually say 7 to 14 days. 21 just seems like a really long time. All right, so let's move on to orthokeratology. We know that orthokeratology is about 2% of all contact lens fits globally. I hope that number is rising. With modern ortho-K designs, instead of just fitting the lens flat, we actually have very fancy reverse geometry designs with multiple curves and zones that give us really great outcomes in orthokeratology. And now that manufacturing with computer-assisted lathes have improved, we have tons of toric designs available, and these help improve our refractive outcomes and lens centration in patients with corneal astigmatism. We know also that orthokeratology outcomes are very similar to other contact lenses, spectacles, and even LASIK. You can do ortho-K on adults. I have several monovision ortho-K patients, and they're very happy with what they're doing. So it's not just for kids, it's for everybody. And it's something that I think the process is fairly streamlined. And if you've never done it, there are lots of resources out there for you to take it up and try it. Safety is always a concern for parents who are fitting their kids in ortho-K. We know that the risk of microbial keratitis is slightly higher in ortho-K than with daily wear soft contact lenses. And that's only because the patient is sleeping in the lens and somewhat balanced out by the fact that we use high decay or hyper decay GP materials. So I kind of just couch it as, it's about the same as a daily wear soft lens. So depending on what you want to do, we have daily wear soft contact lens options, or even daily disposable daily wear soft contact lens options now. But for patients with a corneal astigmatism, orthokeratology might be a better option to control their myopia. So we give patients the option and the different advantages and disadvantages and let them make a decision. We do know that there are some adverse events with ortho-K. Most of them are pretty benign. We see some corneal staining, especially if the lens is binding, if it dries up. You can easily fix that by applying wetting agents before removal and at application time at night. But we always want these patients to avoid contact with tap water because that can be one of the risk factors for these patients. We don't want them to end up with acanthamoeba. I had a friend with 2 cases of ortho-K induced acanthamoeba infection. One was ortho-K related. The patient had slept in lenses and was rinsing with tap water. And the other one was a contact lens, soft contact lens wearer who had gone in a hot tub. So like 2 in the last, few months. Thankfully, I haven't seen any this year. So we just want to always be vigilant in assessing our patients' lens compliance, making sure that they're not contacting tap water. Scleral lenses have really come into our practice in the last decade or so. With modern gas permeable lens materials, we're able to offer these to even more patients. They're more repeatable. The materials are highly oxygen permeable. They're more flexible. We have more options to fit these patients. And especially when the COVID-19 pandemic began, as we returned back to practice in the US in the summer of 2020, I really leaned heavily on scleral lens fitting using empirically based fitting. So rather than putting a diagnostic lens on the eye, which I had done for the last decade, I really started moving toward imaging these patients using our profilometer and ordering empirically based designs. Perfectly happy to have you do it either way. If you don't have the technology for empirical lenses, diagnostic fitting works just as well. There is some people suggesting that empirically based designs are more streamlined for your practice. I would certainly agree they're more hands-off, but you really have to have good data in order to see the effects of that more streamlined fitting process. We also have the benefit here in the US of having very tech-forward impression-based lens fitting in the the iPrint Pro design. And so if for our patients that we can't fit in other lenses, we can do an impression molded fit and help them as well. Challenges with scleral lenses include decentration. I think that's what I struggle with the most, in addition to fogging, which is, I think, what patients struggle with the most. We know that the optical performance is similar to what we'd get in a corneal lens, but when that lens decenters, it can induce prism. The lens can flex if it's overvaulted. All of these can induce residual astigmatism and affect our patient's vision. We do know for a well-fitting lens that we can now incorporate wave front optics onto the front surface of that lens. You need a special technology to read the higher order aberrations in order to do that. But assuming you have a well-fit lens, that is an option, at least for us here in the US. I think we'll see scleral lenses evolving to assist with smart devices. We'll talk briefly about this at the very end. The last report is about the future of contact lens fitting. But scleral lenses right now are really at the forefront of some of our augmented reality and enhanced vision technologies. And I just threw up a photo there of the Mojo Vision prototype lens that is being worked on right now. So I mentioned my patients are most frustrated by midday fogging, which happens in up to 50% of contact lens wearers. The easiest way to solve this is have your patient take a lens out and put it back in with fresh fluid. But certainly if it's happening with your first lens that you fit, you can modify the fit. Make sure you don't have excess clearance over the central tear reservoir or the limbus. Make sure your edges are aligned properly. You can also throw more viscous application fluid in there. We use Celluvisc here in the States to kind of up the viscosity so that less tear debris even gets in there in the first place. And then certainly treating any underlying dry eye and allergy can be helpful. There's been a couple of case reports recently of using ketotifen to help with midday fogging off label here. In terms of conjunctival prolapse, it's one of the other main challenges that we see that can cause issues with patients removing the lens. Some of that has to do with the suction that's created behind the closed system of a scleral lens, which can make the lens really difficult to remove. So you need to take a hard look at your lens fit at that point. But I see this very often in our patients that have conjunctival chalasis pre-existing before we even fit a scleral lens. So I try to be very diligent about looking at the conj before I choose a patient. We also have some evidence to suggest that scleral lenses change intraocular pressure, some evidence that suggests it doesn't. The CLEAR report was pretty ambivalent about it, right? Just kind of saying we don't know enough to know right now. What we do know is that handling of scleral lenses is a primary reason for contact lens dropout, more so than rigid contact lenses. So corneal lens is obviously easier to handle, less tools. The CLEAR report did suggest to help our scleral lens patients along that we kind of give them the idea of a workspace so that they have a clean towel, a flat mirror, and all the tools and solutions that they need in order to fit their lenses. One other thing to think about is that collaboration with the patient's surgeon can certainly help improve their outcomes, especially as it pertains to graft failure and rejection. And if you don't have the technology to help manage that. So we need to be looking at our patient's pachymetry on follow-up visits, endothelial cell count, if we can manage to image it. I know a lot of our PK patients, we struggle with even getting our endo count unit to measure just due to the age of the graft, the clarity of the graft and things like that. But we really want to maintain as much endothelial cell function as we can, a high cell density, low coefficient of variation, high hex percentage, so that our patients don't end up in graft failure or rejection and can successfully wear, especially a scleral lens, because it's going to put potentially more stress on that graft. I'll just pause here for a quick chuckle. When I was reading these reports, my friends know me as a very diligent editor. And so when I was reading the report, I had a little chuckle at this, please adjust spacing, because someone left that in there and it wasn't supposed to be in there in the scleral report. So if you're reading that in the middle of the night and you see that, you can think of me, or maybe they've eliminated it from an updated version by now. Let's move on to contact lens complications. We know that complications are basically any adverse event caused by contact lens wear. Generally, our patients are symptomatic when these happen, and they seek our assistance, right? These are the patients that call your office at 3 a.m, or are on your emergency line, usually at Friday at 4 p.m. or while you're on vacation, right? They need us. They need our assistance, and we certainly want to help them, and we would rather they not go to the local hospital or urgent care. Complications generally mean our patients have to cease contact lens wear for a short period of time. Sometimes it's a longer period of time to help with pharmacological intervention, or maybe they just need to be out of lenses altogether to give their eyes a break so that their eye can recover. May not require medication per se. So here's a list of pictures of some of the contact lens complications I've seen. I think some of my more fun ones. We have some neovascularization over here on the left from a scleral contact lens, neovascularization on the bottom from a soft contact lens, papillary reaction on the lower lid, some really intense deposits on a soft contact lens, and then some conjunctival, the word is escaping me at the moment, hypertrophy, conjunctival hypertrophy from a scleral lens edge fitting too tight over here on the right. So the CLEAR report lists out the complications you might see. I'm not going to go into these, but certainly this is another one of those, if you're studying or really into this, go to the report because it lays out the different categories of complications: infectious, inflammatory, metabolic, mechanical, toxic, or allergic. They kind of group together, dry eye related complications, and then discomfort. So this is the one you want to go to for tables. It has the most heavenly tables. Is like one for every one of these, and it lays out the etiology, the treatment, and the different things that you need to know about all of these complications. And there's 32 different complications that they came up with to talk about, which when you think about it is just like kind of mind-blowing, the expertise that we need as eye care providers to figure out which 32 of these complications, which one or two are most likely, and how do we treat those expediently so that our patients can return to contact lens wear. So good on you, those of you seeing these complications. One other thing that the report identified was that we really haven't had any good prospective studies of microbial keratitis since the mid-2000s. So we don't really have an estimate of the rate of microbial keratitis with our, what I'll call contemporary, meaning, the 21st century contact lens materials. And we don't really have those with Ortho-K or soft myopia control lenses, which really have come into play in the last couple of years. We do know from our clinical trials that data is starting to become available and will be more available to us in the coming years, but some updated rates of MK would be welcome. The report also highlighted ways to reduce the infection risk, specifically for microbial keratitis, reminding our patients and all of us that we need to avoid overnight wear, sleeping in lenses. We need to maintain hand washing practices, proper lens and case hygiene. As eye care practitioners, we really need to fit these patients in daily disposable lenses when we can, when the parameters allow us to, when the circumstances allow, and then also to promptly help these patients when they call us. And I think on the flip side of that, letting them know, reminding them of these are the signs and symptoms of a potential complication. Please call my office if you're having a problem so that I can help you. One other thing that I really loved about the report is it called out, our ability to deliver this patient education to patients. We are the ones that see contact lens wearers for their annual exams. I'd rather they get this information from me than from a YouTube video, right? And something that can be useful that the BCLA can provide is these no water stickers. And I think actually you could even design them for yourself if you don't want to get them from the BCLA, but you can purchase them from their website just to remind patients not to have tap water come into contact with their lenses. So there was actually a study that showed that the presence of that sticker on your contact lens items, like what your box is or your, solution bottle, helped reduce the chances of adverse events related to non-compliance. So we mentioned daily disposables earlier. While they don't decrease the absolute risk of microbial keratitis, we do know that daily disposable wearers have less severe microbial keratitis and less irreversible vision loss if they do get an infection. So again, all the power to daily disposables today. We know that contact lens wearers experience altered meibum in their meibomian glands. They have suboptimal meibum quality. We don't necessarily know the relationship between that and contact lens dropout, but we do know it causes some level of contact lens discomfort, and that potentially could cause dropout. Again, what the solution for that is, we do not know. But it's on us to be proactive about managing the early clinical signs of MGD for everybody, but especially in our contact lens wearers, rather than waiting until it gets to be too problematic for the patient. One more note on complications, because this is kind of buried at the end of the report. I thought it was really interesting. They called out colored lenses specifically. So any lens worn not for refractive correction, but more for cosmetic use. They said in the population in Singapore that wears contact lenses, over 1/3 of their contact lens use is cosmetic. So colored lenses, circle lenses, decorative lenses, lenses that change your eye color or appearance. I thought that was so interesting. Most of these patients are young women, new to contact lens wear. They get their information from social media. And the concern is always that they're purchasing, at least in the US, our concern is they're purchasing contact lenses without a prescription. They've never been evaluated by an eye care provider, and they're not getting the training and education that they need. And in the CLEAR report, they suggested that there's also the risk of getting an inferior quality product. So the key take home here is, and you can share this with all your cosmetic or colored lens wearers, is that there's a 14 times higher risk of infection in patients that wear lenses for a colored, a decorative use, a cosmetic use, versus those who wear it for as an alternative to glasses or for refractive correction. And there's lots of challenges to this all over the world in terms of supply chain, where these lenses are coming from, who's regulating it, what the quality control is. So I don't know that it's something we're going to get under control anytime soon, but it's certainly something to look out for in patients that have adverse events. Ask them where did they get their lenses from, and take the time to educate them on how to do better. The next report is the medical use of contact lenses report. prior to the CLEAR report coming out last year, we didn't really have a definition of when contact lenses were medically necessary or what medically indicated contact lenses were. And so I think one of the great values of this whole series of papers is that we now have that definition. So medical contact lens is any type of contact lens worn for the primary purpose of treating an underlying disease state. So treating disease, or this is the best part, complicated refractive status. And I think historically, there's been a huge disconnect between disease and ametropia or refractive status. And as eye care professionals, we know that those two things go together a lot of the time. Our patients that have complex refractive status, they don't want to wear contact lenses as an alternative to glasses. They do not have glasses as an alternative. They cannot comfortably or effectively wear glasses as a primary form of correction. They need contact lenses in order to see. So this applies to soft lenses, hybrid lenses, scleral lenses, all types of lenses, and may or may not correct refractive error in addition to helping with the disease state. But these are not just patients who go back and forth between glasses and contact lenses for convenience. They really need their lenses for a medical reason. So there's two subtypes here, therapeutic or bandage lenses. These are the ones that are more indicated for disease states. They help with ocular discomfort. These would be what you'd think of as a bandage lens, say for a corneal abrasion or filamentary keratitis or exposure as an alternative to a tarsorrhaphy, things like that. Also, a big part of the report was post-operative in terms of a PRK or LASIK. The use of a bandaged contact lens for that is shown to support corneal healing. The second version of medical use of medical contact lenses is rehabilitative contact lenses. So these are the ones that help our patients who cannot get adequate visual function out of spectacle lenses. The patients who are -20, who have irregular astigmatism, either from post-operative, from trauma, from other corneal disease, or the ones who have anisometropia, right? Huge difference in refractive error between their two eyes. They cannot fuse in contact lenses. They cannot fuse in glasses and cannot effectively wear glasses. What's also kind of wrapped up in here is our prosthetic lenses for patients who need an artificial pupil or an occlusion device. This is helpful for them. So two big buckets there. All right, so let's launch I think this is our final poll question.
Yes, this is, again, this question, you can choose multiple options if you think, more than one option is correct. So which are the two items which we are assessing during slit lamp examination to ensure that soft toric lens optics is working well?
Optics being the key word there, you guys.
Yep. All right. So let's give people another 10 seconds before we could end this poll. Okay, great. So I'm just going to end this and share the results with you. So majority of them think is the rotational position, around 70% of them. And then the second one is the push-up test. And probably very close by with the rotational stability there, right?
Yeah, I love it. All of those are really good things to look at when you're assessing a soft toric lens. Absolutely, you need to look at all those things. But there are two out of those four which are really important for the optics of our contact lenses, not just the fit, but the optics. And we'll talk about that in a minute. So when we're looking at a soft toric lens, again, this is the optics report. So if, again, you're a huge nerd about optics, this is the place to go. So for soft toric lenses, some of the key components here are that when we look at a soft toric lens, we need to look at the position of the rotation. So how many degrees is it to the right or to the left or clockwise or counterclockwise or anti-clockwise? There's a lot of different ways to say it. Clockwise or counterclockwise, how many degrees? So that's the rotational position. So like here, you've got maybe, I don't know, 1 clock hour to the right. So maybe it's 30 degrees to the right. We also then need to look at the stability of that. So is it sticking to 30 degrees to the right, or is it kind of nudging back to 0 and then maybe even going to the left sometimes between the blink? If you go away and come back 5 minutes later, does it look completely different? So that's the stability. Is it always 30 degrees to the right? If it is, then that may not matter so much to your patient. So you can have a position that's off. We can adjust for that using the LARS technique. But if the stability of the rotation is off, that's going to affect the patient's vision. So we want to assess the rotational position and the rotational stability. And those are the two things that affect the optics the most. Certainly, centration is an issue. And if you have a decentered lens, yes, your vision will be poor. But I would beg to differ in that if you put a soft toric lens on your patient, one that comes off the shelf out of a package, the chance of that lens decentering enough, like that it's totally off the limbus to affect the optics, are probably pretty small. Most soft toric lenses have a large sagittal height. They're very compatible with different eye shapes. And that's probably not the first thing that I'm going to look at in terms of vision. So other things about optics, just some highlights. We know that low contrast VA is reduced a little bit in multifocal contact lenses. That's expected, but the CLEAR report did suggest that there's little difference in high contrast vision in terms of distance vision when we compare multifocal lenses to single vision. So if we're looking at high contrast Snellen, multifocal lenses, very similar to single vision lenses. It's when we go into low contrast VA, which I don't know about you guys, but I don't measure that on a routine basis. But that is where we can expect some reduction with a multifocal lens. These lenses also require up to 2 weeks of adaptation in order for your brain to neuroadapt to the different multifocal optics, right? Your brain's usually used to single vision optics. When we throw multifocal soft lens on there, all the optics are going to the brain at once. And so it requires a little bit of patience and persistence on the part of the patient. And I think this is something where we can provide that information to the patient up front and let them know it's going to take a couple weeks to adapt to this. When we predict visual performance of multifocal lenses, really standard VA charts, even if they're high contrast, are inadequate. It doesn't translate necessarily to our patient's satisfaction with their multifocal lenses. So what's the best solution to that? Have the patient go out in the waiting area or out and look outside at what they're normally going to be looking at, and have them use, a newspaper, a magazine, their mobile phone up close as their near point. So instead of Snellen distance and a Jaeger card at near or whatever you want to use, those numbers don't matter so much to me, but can they see distance and can they use their mobile device or read the newspaper matter more to me. So those real world tasks are really important to our assessment. The CLEAR report also confirmed for us, again, that the evidence shows not a single multifocal design works for all patients. This is why we have different multifocal designs. What doesn't work for one patient might work for another. And if your patient is not doing well in one design, they may find lots of success with an alternate design. And then also that our initial fit performance may not predict long-term performance. So again, what we're getting day of as we fit may improve over time. Patients may feel like as they neuroadapt, the performance of this lens improves over time. And the patient may also need adjustments to their multifocal lens over time in terms of adjustments to the distance vision or the near ad. So we need to be proactive about recommending contact lens wearers because we know that contact lens wearers lapse in their wear. They drop out of contact lens wear. And by the way, we've moved on to the evidence-based contact lens practice portion of the CLEAR report, which if I had to pick one of these to read, this is the one that I would recommend to you, that I would choose to. I think it's made the most impact on me in terms of medical decision-making for my contact lens patients, and also like great reminders about best practices or things to do with my students. So why do established lens wearers lapse in their contact lens wear? It's usually because of comfort. It can be because the product didn't meet their needs or wasn't, what they envisioned. And it could also be because they are blaming you, right? Which I hate to say, but the CLEAR report shows us that the evidence points to sometimes we are the very problem. So I find it very helpful to be super positive and encouraging with my contact lens patients, right? If they have a problem, you say, hey, we can solve this problem. We have new technology. Let me offer you the best that I have. I have something else we can try, right? I just try to be very positive and proactive about offering them the best of what I have, so that they know that this isn't the end of the road, and they don't, drop out before coming back to me and saying, hey, this didn't quite meet my needs. What else do you have? They also might think you're not super competent. So I try to, again, highlight technology that's in my practice, fit daily disposable lenses to try to, keep up with what's new and what the trends are and what's safest and most convenient for my patients. Just a quick note about monovision. While it is fairly successful, I think multifocal lenses can certainly beat this success, depending on if you're following the fitting guide and choosing the right candidates. We have very good multifocal options available these days. We don't have to disrupt our patient's stereo. We don't have to create binocular rivalry. We don't have to affect the way that they walk around and affect their changes in gait, like we used to get with monovision. For patients that have a lot of intermediate tasks, monovision can also be a challenge. And I would argue that in 2022, a lot of what we're doing is at that intermediate distance. And so in my patients that wear monovision, I am adjusting it to be kind of distance and intermediate, but they do find that they lose that near vision, and some of them are a little disappointed about that. And so then I just move them on to a multifocal. It's important to also remember that monovision fitting can cause your patient to have a decompensating phoria, and you can kind of tip them over the cliff there by putting them in monovision. So we want to make sure that we're doing a nice binocular vision assessment before we fit these lenses, so that we make sure we're not inducing any sort of binocular vision issue. This is just kind of, it's part CLEAR report and part my soapbox. But I think everting the upper lid is crucial for all of our contact lens patients. And I'll just show you real quick how easy it can be. So this is a patient who came back for an annual exam feeling fine, wearing their lens. I flipped their lid. What's underneath? All of this, right? That looks terrible, right? There's hyperemia, there's papillae, there are actually scars from very severe episodes of previous GPC. And if I didn't evert the upper lid, I never would have seen that. It was not that degree on the lower lid. So very critical that we evert the upper lid on every patient. I tell my patients, this is the thing my patients hate the least. This is my least favorite thing to do to you, but it's very important that we do it. So every annual exam, every new fit, so you get a baseline, any patient with a foreign body complaint, any complaint of itching, and then any patient that has excessive lens awareness, because that can be a sign of giant papillary conjunctivitis, like you see here. One other cool pearl I picked up from the CLEAR report is they cited a study that showed that the optimal device for everting the upper lid is a finger-shaped everter made of silicone rubber, which is this little lid stick device. This is the opposite end. It's like a little plastic thing and it has a measuring stick on it. But you can use that and it kind of hugs the upper lid, and you can use it to evert both lids. So certainly not something I use in my daily practice. I just use my finger or a cotton swab, but If you have a finger-shaped everter made of silicone rubber, it might make your life easier. Clinical grading scales, just a quick word about those. Remember that when the grading is more than grade 2, we probably need to do something about it, either treat it or change something that the patient's doing. We usually grade them in half steps from 0 to 4. And if your patient goes from, like, let's say grade 1 to grade 2, that is a clinically significant change. If they only go from 1 to 1.5, it is not. And it's important to note which scale you use. Did you use the Efron scale? Did you use the CCLRU scale? Which scale did you use to grade this patient? Or maybe in your practice, you just have one that you use specifically. One other pearl that I pulled out of the CLEAR report was when we're grading that upper lid palpebral conjunctival reaction, that level of papillae, it is very helpful to assess that with fluorescein and a blue light versus white light. And I kind of cheated here. This isn't exactly, so the left image should just be with no dye and white light. But what happened is I messed up the light and I put the dye in too fast. So, but even I think by putting the blue light filter in, you can see the highlighting of the different areas of papillae. So, to kind of go from the right to the left, it helps to see the different outline with the dye. Here's another one where I think that is visible. So this is another upper lid, and you can see the little fine papillae there that are really highlighted by the dye that's getting in between the little crevices. So very important to not only evert the upper lid, but also look at it with fluorescein and blue light so that you can better grade it. One note on lid parallel conjunctival folds, if you've never heard of these, they're called lip cough. The etiology of them is unknown, but you see here in this image, the little arrows are pointing to the conjunctival folds that are running horizontally, so parallel to the red line, which is the lid. These are folds of conjunctiva that predict contact lens discomfort. So something nice to look at before you fit a patient. But also if they're coming back complaining of discomfort, that can be, something you look at. Do they have lip cough? Oh, well, that might be why they're complaining of discomfort. Again, one of those things we don't know enough about it yet, but it is something that I look at in my pre-fit assessment. Back to dyes for a moment. We know that we can see damage to the ocular surface. Using dye strips is generally what we use at our clinic. They are sterile, they last a long time, they're not super expensive. The CLEAR report taught me that I should place 1 drop of saline onto the paper strip, shake it to remove the excess, and then apply the strip flat at the temporal canthus to avoid damaging the tissues that I want to look at. So that's the best practice for applying the strip. If you put in excess fluorescein, what happens is all those fluorescein molecules bump all around. You don't get optimal fluorescence. You need to wait a little bit longer. So you try not to put in too much. And then you also want to wait between 1 and 3 minutes after you put the dye in to get the best fluorescence possible. So if you look in that first minute, again, you're probably going to have too much fluorescein. You're not going to get a nice assessment of the fluorescence. And then if you have that Ratten filter or yellow barrier filter, it helps to combine that with a blue light to highlight any of the corneal staining or staining of the conjunctiva or the palpebral conj that we mentioned earlier. Lissamine green is another vital dye used to assess the conjunctiva and the lid margin. With this one, you want to wet the strip with saline, and then you kind of hold the strip parallel for about 5 seconds, which is kind of like a balancing act. I'm always like, don't spill the lissamine on my patient. Don't stain your clothes. That 5 seconds, though, really gives that dye a chance to pick up the saline, and you get a much better delivery of lissamine to the patient's inferior cul-de-sac. So you have them then look up, and you kind of just tip the dye into their inferior fornix there. And with this one, again, you want to wait 1 to 4 minutes after you put the dye in. I tend to wait a little longer on fluorescein, maybe not as much on lissamine, but I will say if I totally accidentally flood the eye with lissamine, I will wait longer because it can give you a false sense of staining if you observe too soon and you put in too much. One thing about strips is that they can vary depending on how much dye is impregnated on the strip. So if there's different manufacturers of lissamine green strips, you may find some work better for you than others. I also really like the liquid dye, although it's very messy. So the strips are what we've used ever since COVID. When we're talking about soft lens assessment, we want to look at different factors. The CLEAR report suggests we look at post-blink movement. They call that B. Horizontal lag, they call that L. And push-up recovery speed, they call that P. They suggest a 3-point scale being, is it doing it plus, is it not doing it minus, or is it just kind of normal, 0? They combine those 3 factors, their scale of 3 points, with a comfort score on 0 to 10, and then what the centration is. And that's their method for soft lens assessment. I'll draw it out for you here in a little graph. I will say I find this quite cumbersome and I don't use it clinically, but I do think research-wise, it's quite a good consistent scale to use. Or if you set up your charts to be this way, I could see how it would be easily integrated. So are you getting a 0 on P or B, P, and L here? And then where is your centration of your lens relative to the center of the cornea? And then you can list your comfort and your covered score up there on the top. For a rigid lens, it's a little bit different. You want to apply the dye and wait about 30 seconds before looking at the lens. Again, if you apply too much dye, it may give you a false steep pattern. So be very judicious with applying your sodium fluorescein to a gas perm or a rigid contact lens. I'll pause here just to give you one other pearl that I didn't actually talk about on a slide, but is one of the takeaways. We talked about terminology way back at the very beginning. I was trained to call rigid corneal lenses gas permeable corneal lenses or gas permeable lenses. And the consensus out of this report is that we should be calling them rigid corneal lenses instead of GP lenses, because really all contact lenses are gas permeable. So that's why I'm using the term rigid corneal lens or RCL here. I still feel like I will be on team GP lens until I die, but I understand the desire to standardize what we're calling it. So corneal lens or rigid corneal lens is what they're calling it here. There is, again, a little bit more complex than what I prefer. Fitting assessment outlined here. Kudos to the people that came up with this. I think it makes complete sense. It just, and for a research perspective, I totally see how it's helpful. So if you want to dig into that, it can be helpful to you if you're trying to learn how to assess a rigid corneal lens. Last one here, a little bit about future as we wrap up. Contact lenses are really going to go beyond the correction of refractive error. We'll see more and more designs, I think, for myopia management, contact lenses that integrate IOP measurement. And we've even seen antihistamine releasing contact lenses come out since the CLEAR report was published. So I think there's a ketotifen releasing daily disposable lens that is now available in some places. These technologies will also help us monitor not only ocular disease like glaucoma and dry eye, but also has the potential to help practitioners monitor systemic disease. So things like blood sugar and diabetes, or the presence of various inflammatory markers in cancer. And they're calling this theranostics, which was a term that I hadn't heard of until I read this report. But it's combining the monitoring and treatment of certain conditions into one device. So I think it's really interesting to think about what the future of contact lenses is, and also how we as eye care providers fit into that role. We can work with primary care physicians to help monitor and manage patients' systemic disease as well. Certainly, we want to see enhanced safety in any future technologies, especially if these roll out to more neophyte contact lens wearers, and if they carry with them more complex contact lens technologies like the scleral lens we looked at earlier for augmented reality. So, incorporating things like antimicrobial resistance in a contact lens or in its case, innovative cases, packaging that helps patients remember not to use water and when to replace their case and things like that, as well as the addition of all those electronics. These have the potential to not only help our patients with reduced vision or low vision and vision loss, but also just kind of help us do what we want to do in our daily lives with that augmented virtual reality type thing, heads-up displays, and all those sorts of things. Also, something for our presbyopes, which I will soon be one. There may be some technology there that can help our presbyopes focus at all different distances. So thank you for letting me go a little bit long just because there were so many reports to get through. I really enjoyed putting this together for you. I hope you enjoyed this high-level overview, some little tips and tricks to share. And I also hope that you'll dig into the reports individually that you found really interesting or that you think apply to your practice. And I'm happy to answer any questions that you have as well.
Great. Thank you. Thank you so much for, concisely putting this for us. I think these were really the most important, I would say, clinical tips which you have shared, and we can always bring all of these along when we go back into practice and see how we can incorporate them slowly and steadily, if not all of them at the same time, right?
Mm-hmm.
Awesome. Great. All right. Great. So this is the first question. I think you did mention that we do want to encourage patients that don't rinse off the solution before putting in the lens in a fresh pack when they open their lenses. So do you think it is different between different modalities, or are we just talking about daily disposables can be just directly worn?
Yeah, no, great question. Thank you for asking the question. I was really speaking to daily disposable lens because I find that that's where it comes up the most with my patients. So they'll come to me and say that they were told to rinse their lens off, or they're rinsing and then they come in with a problem. And it's like, well, this is a daily disposable or a single use lens. It's preservative free. Why rinse it with solution that might have things that your eye is sensitive to? Or maybe that's the reason we took them out of frequent replacement lenses to begin with, was because they were having solution sensitivity. And so I certainly don't want to carry that over if we don't need to. To kind of what I think is the other point of the question, I am not a contact lens manufacturing expert. So I don't know that I know if there is any correlation between modality and where the wetting agents are immersed in the lens, right? So we talked about the different, they can be immersed inside the lens matrix as a coating on the lens and then in the lens packaging. I do think that there tends to be more wetting agents in the packaging of a daily disposable lens versus a multi-use lens. And it goes back to what we talked about at the beginning, which is the patient just takes it out and puts it on. And so they don't have the advantage of refreshing those agents with a solution, or at least they shouldn't be. And so that may be more in the packing solution, but I certainly know there are daily disposable lenses that have agents that release over time and agents that are embedded in the lens. So it's a combination of all of them, how much they can stick in there and make the lens cost effective and still useful.
That's right. Yeah. And the other question is about the cosmetic lenses. We did talk about there's a huge population who do wear lenses. Would there be any reasons why the risk of infection would be higher in those compared to the refractive correction or the clear lenses?
Yeah, great question. I think there are studies out there, but my clinical intuition and from reading this report would suggest to me that patients that wear cosmetic lenses or colored lenses may not always receive the patient education training that they would if they were fit in our office. And so at least in the United States, those lenses are supposed to be fit by a practitioner, prescribed by a doctor, and purchased by the patient from whatever channel, but with a prescription. Okay. And I think overseas rules are different, but it may still carry that unhealthy practices are kind of part and parcel of colored lens wear for whatever reason, patient population, lack of education. These also might be patients that aren't coming back to see us every year, right? Maybe they saw us once, but they're not coming back. Or maybe we gave them a clear lens, but they're getting their colored lenses elsewhere or from a source that is not reputable, buying them without a prescription. And so they might be getting their education from Dr. YouTube instead of, Dr. Sicks. So I think that inherently increases a risk of a contact lens related adverse event, right? Not necessarily, that they're going to get a microbial keratitis, although that risk may also be higher. But certainly we see, and I have seen corneal ulcers, corneal abrasions from cosmetic contact lens wear, even here in the States.
Yeah, that's right. I would totally agree. Cosmetic lens wearer gets their lenses from unreliable sources, and there are many of them available now, even in the flea markets, the night markets and things like that, where they can just pick and choose what color they like. We really don't know the authenticity of those lenses, and that could be one of the reasons which we are looking at in terms of getting more complications in those patients, right?
Yep.
Okay. And we also touched upon toric lenses. And what would you do if you have a rotational instability? What are your thoughts and your advices for this?
Yeah, you guys are asking such good questions. I'm so impressed. So rotational instability is really interesting because it depends on the toric lens that you're fitting, okay? If you were fitting a custom toric lens and you had rotational instability, you could change the fit of that lens to improve the stability of the rotation, meaning you could increase the sagittal height, which would usually mean making the diameter larger. It may mean steepening the base curve in conjunction with that, and that will improve the stability. Other options you have are changing the ballast system, or what holds that lens in place. So is it a prism ballast? Is it a peri-ballast? Is it a thin zone design? If you have the opportunity to change that, usually in custom lenses, at least in the States, most of them are prism ballast. So if we have a rotational instability issue, we increase the amount of prism in the lens, along with some of those other changes that I talked about. But if you are just fitting a lens off the shelf, like what more than likely what you will be doing in your practice, and that lens is not stable, there's a couple of things you can do. I think the simplest thing to do is wait, because maybe it just takes 5 minutes for that lens to kind of settle, right? Especially on a new wearer who might be tearing a lot. And these lenses take, a few minutes to settle, okay? The second thing, though, that you can do is just change the lens design. So if you're fitting, lens brand A, just go to lens brand B. Even if you don't know how those toric stabilizing systems work, just changing the lens might make it more stable. If you do have the advantage of knowing what system it is, so is it prism ballast, then I just change the ballasting system or the stability system. So example, if I'm fitting a lens and it's prism ballasted and it's, a lens off the shelf from my fitting set and it's not stable, I will not switch the patient to another prism ballasted design. I will switch them to a lens that has a thin zone design, because chances are the ballast system is not working for the patient, right? That's not 100% of the story all the time, but it's kind of taking one element out of the complicating factor so that I can try to solve the problem.
That's right. Yeah. And another one on toric lenses is a bit on over refraction side. So we do always do our over refractions to kind of finalize, the lens power. And sometimes the over refraction astigmatism axis is always different compared to the patient's axis, even though the contact lens axis was right. Have you faced this, and anything which we can do about, getting things right in that?
Yeah, this is always a challenge, right? So a couple of things I tell my students, okay? If you're fitting a soft toric lens, your number one goal is, well, one, you have to have accurate refraction, which you astutely pointed out, right? Love that. Vertex convert, choose the closest lens that you have with a bias toward getting the appropriate axis first. Okay. If you don't have a lens that's even remotely close, like we in our practice will just say, sorry, come back another day, we'll order it. Okay. Because it's not really worth putting on a lens a patient can't see through. Okay. If I put a lens on, then my number one goal after that is to get them to see 20/20 or whatever their best vision is with only sphere only. Don't go fishing for SIL. Don't do a spherocylindrical overrefraction off the bat. Just do sphere. Because I tell my students, I'm like, if you can solve their problem by just incorporating sphere, you have won, right? You just go to the shelf and you pick the next sphere. You don't have to change the SIL. You don't have to change the axis, right? Now, we may still Lars adjust if that's part of the issue, like the lens is rotated. But in terms of best vision, sphere only, okay? So now let's assume if you made an adjustment, you're doing sphere only, you can't get the patient to their best vision. Now you can do a spherocylindrical overrefraction, which is where you're at, I think, in this question. Okay. So what you've basically just described is doing a cross cylinder calculation, right? So your patient has a lens on, your patient has a refractive error, they have a lens on, you have put something in front of their eye that helps improve their vision, and you want to give them that vision in a contact lens, okay? So what you then need to do, and the easiest way to do this is to go online and find a cross cylinder calculator or crossed cylinder calculator. There's one, I think, if you search TorTrack, there is one, or there's several versions that you can look up. You put in the patient's refraction, you put in their contact lens power that they have on, you put on in their rotation, and you put in your overrefraction, and it will calculate your next best lens. I just did this last week at my practice for a patient wearing an extended range toric lens. For some reason, they couldn't see, and I just was like, well, let me do the cross-sil calculation later. And it came out that he needed like more sil and a rotational change. So the reason for it could be many, right? It could be your refraction is off. It could be the lens isn't stable. It could be they're now, let's say you send them home with the lens, they come back, they're now adapted to some of that sil. They're now taking more. The lens is not stable. There's lots of reasons. But if you need it, only if you need it, you just do that cross cylinder calculation with your overrefraction, which in this case is your retinoscopy. And then you can calculate the next best lens.
Right. Yeah. I think the best would be to putting the lens, as you said, as close as possible. And I think most of the time it does solve the problem. You might get this kind of problem in a very minuscule number of patients, but that cross-cylinder calculator would do the job, right? Great. Okay. A couple of more questions. We'll just take them in. I heard that you are a fan of multifocals compared to the monovision, right? But any thoughts on, are there any category of patients you would still, prefer monovision, or would you want to add on something on those?
Yeah, I don't mean to like stomp on monovision's parade. I think there are definitely, if you come into my practice, I have patients wearing monovision. I think it is very helpful for people who are very strongly one-eye dominant. Also for patients that have a lot of astigmatism. And I think, I guess I couch that with, at least here in the States, we have several now multifocal toric lens options that are quite good. It wasn't the same 5 years ago. And so I was fitting a lot of toric patients in monovision. And now I can move those patients over. But it certainly has its place, I think, for patients that have a very concrete need for only two distances. Mm-hmm. For patients who don't drive, I think it can be helpful. So yeah, I think mostly where I see it is strong dominance or patients with a lot of astigmatism.
Right. And is it possible, or have you ever seen lens flexure in terms of soft lenses, and could fitting play a role to probably get the lens flexure or anything on those lines?
So flexure is really, if we're talking formally about flexure, it's kind of a GP lens term, right? A corneal lens term, or even a scleral lens term, but it applies to rigid materials, right? Because the rigid part is flexing on the eye. Perhaps what you're referring to is, there is a tear film underneath a soft lens. And if you fit it too steep, that tear film could potentially interfere with your best corrected vision. I don't know that I'd see flexure of the lens itself necessarily. I guess I'm not a physicist, so maybe I'm not the best person to answer that. But you certainly could have visual repercussions from a soft lens that fits too flat or too steep. That is true. And whether you want to consider that lens flexure, kind of, if that makes sense to you, I think that's fine. But it's technically not flexure in the same sense.
Correct. Yeah. All right. And any comments on the effect of the lighting conditions when it comes to multifocal wearers? Does it have any effect? Would you, take that into consideration while prescribing multifocal lenses?
Yeah. I guess I feel like before I read the clear report, I could buy that it has some effect, right? You kind of inherently agree that in bright light conditions, your pupil is going to be smaller, and in darker conditions, your pupil is going to be larger. And I think that affects the, I guess, functionality of what you might get from a multifocal lens. But the evidence doesn't show that it really affects lens success rates. And to that point, I think it's not something you need to necessarily think about, except in a general sense for everybody, right? So I tell my patients, like, hey, you may notice when you're in a dim restaurant, you may need extra reading glasses, right? And it's okay to put those on because, and in my head, I know what's happening is their pupil is larger because it's dim. And so they're not getting the same optics to the same parts of their brain that they're used to. They're now getting, less near, more distance or something because their pupil is larger, right? So more optics going to their brain. The opposite might be true in really bright illumination, right? Their pupil gets smaller. Maybe they're not getting as good a near vision, right? All of this makes sense to me in my head, and I think to you guys. But the clear report does suggest that it's not something we need to take into account when we're fitting multifocal lenses. And I think perhaps a lot of that is just in our multifocal lens options, the ones that we generally use, we can't determine or specify, I guess is a better word. We can't specify the patient's like the zone sizes, right? They're proprietary. So we don't know them and we can't pick them and we can't change them. So I guess I would approach it more from a marketing perspective, which is like, if you're going to sit there and say, this lens works better because it has different pupil sizes, I don't know that we have enough evidence to show that that makes a huge difference. It might make a difference in something. We just don't have the evidence. So I'm not putting it down or saying anything bad about it. But it's certainly not something I think about when I'm fitting a lens. Maybe if I'm fitting a custom lens and I'm troubleshooting, then I will think about the patient's pupil size. But if I'm fitting off the shelf lenses, it's like it either works or it doesn't. You just have to go with it.
Go with it. Right. And we'll take one last question here. And I think this is something which is being asked quite often on what is the recommended type of lens when we have patients with dry eyes and who suffer with dryness. Any to-go lens you recommend?
This is a little bit fraught here in the States, at least, because there aren't lenses that are indicated for dry eye. And so I can't sit here and say like, this lens is better for dry eye. What I can say based on the evidence, and I'm sure there's a section of the CLEAR report that talks about this, but I can't exactly remember where it is, but more frequent replacement, meaning, and that means daily disposable or single use lenses. It doesn't necessarily mean 2-week versus monthly. We know that when a patient has a fresh lens every day, that their wearing experience is better, their optics are better. And I think that goes along with problems that patients who have dry eye have. And then the other thing I will say is the report does really emphasize that we need to co-manage any pre-existing ocular surface disease, allergy, and dry eye with either re-wetting drops, prescription medications, and things like that. So the contact lens isn't going to solve the problem. It's right. We talked about how it's not inherently going to improve wettability, right? It's only making things worse. It's certainly not going to make things better. And so we have to do everything we can to keep on top of the health of the ocular surface and make sure that it's optimal for any contact lens that we put on it. And I guess the last thing I'll say, kind of without an evidence-based hat on, is just, every person is different. And again, there's so much we don't know about contact lens discomfort. And I think dryness ties into that just because a lens doesn't work for one patient doesn't mean it won't work for another. And just because a patient is unhappy in one lens doesn't mean they can't wear a contact lens. You just haven't found the right lens for them.
That's right. Yeah. So the bucket is too large and our toolbox is too much to explore, and we can always help most of our patients in some or the other way, right?
Yep.
Awesome. Great. So thank you so much. I think we have taken all questions which popped up on the chat. Thank you so much again for, spending a Sunday morning with us, discussing the CLEAR reports and sharing your views and thoughts on the questions which popped up as well.
Yeah, I had so much fun. Thanks for having me back.
Thank you so much. So to the attendees, we do have session planned in a couple of weeks. Take care, be safe, and I will see you in the next session. Bye-bye. Bye. Have a good Sunday.
Bye, you too.
Bye.
Thanks.
See you soon. Bye. Yeah.